It's my pleasure to welcome everyone to the talk. But before we get started, I did want to take a moment to acknowledge the land that Rethink was founded and settled upon and thank the original caretakers of this land. It's the traditional territory of several nations, including the Anishinaabe, including the Mississaugas of the Credit and the Chippewa, as well as the Haudenosaunee and the Wendat peoples, which is home to many diverse First Nations, Inuit, and Métis people today. This sacred land is covered by Treaty 13, signed with multiple Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississaugas and Chippewa bands. Rethink stands in solidarity and allyship with the Indigenous peoples of this land and their fight for land, self-determination, and decolonization. And now I would like to introduce someone a lot of you will be familiar with because we've had her back a few times. This is her third time doing a Zoom with us, Dr. Brezden-Masley. She is an MD, a PhD. She's a practicing medical oncologist and the director of the Marvell Koffler Breast Center at Mount Sinai. She's also the medical director of their cancer program. I'm going to read a little bit because she's done so many things. She does too many things. She's the founder of the COMET Clinical Trials Consortium. She's the founder of COMET, which stands for Community Oncologists of Metropolitan Toronto Clinical Trials Consortium. So she's really knowledgeable about clinical trials. She's a leading clinician scientist in Canada and presents at conferences all over the world. She treats both breast and gastrointestinal, colorectal, and gastro cancers. But her major areas of research, which are her major areas of research interest, but she also does clinical research on cardiotoxicity from cancer therapy. And on top of all of this, she is a longtime board member with our organization, Rethink Breast Cancer. So we are grateful to have you back tonight to meet with us and chat.
Thanks so much, MJ. Hi, everyone.
Yeah. So this talk that we wanted to organize is coming off of, it's been another crazy year. We're still working our way out of the pandemic. The cancer system is recovering. We're all, feels like there's positivity out there, but it's still feeling pretty hard for a lot of us, just catching up almost and still finding our way through this. So I think it's been, maybe better than 2020, but still another intense year. At the same time, we've been so excited about all the new cancer treatment news. So that was really the focus we wanted to have today, was to get some updates on, I know you've been attending and probably presenting at some of these conferences. And, we see the updates. It's been easier forever than for patients to attend things like ESMO and ASCO and San Antonio Breast Cancer Symposiums coming up. And the nice thing about COVID is we're learning how to just attend these virtually as patients, but it really, really is important that we have someone like you helping us translate and understand kind of all this new exciting data around breast cancer. So that's kind of my over to you. I don't know how you want to even approach this. Like there's new stuff in triple negative, in HER2 positive, in early setting, in metastatic setting. And I'd love to cover a little bit of everything. And then we do have lots of questions from our community as well.
Sure. So I despite COVID and despite the fact that clinical trials were halted a little bit in 2020 when COVID hit us, obviously in March, April, May, June, and again in October, November, it has been a prolific year for results coming out for breast cancer. And this is really echoed by our recent meeting, which is the European Society of Medical Oncology, which was in Paris. Next year, we'll hopefully be live in Paris and in person in Paris. But this was a hybrid virtual in-person meeting. And it was packed full of new data and very exciting data for breast cancer patients. In fact, one of them, had it been an in-person, would have achieved a standing ovation. And this was the called Destiny Breast 03 in HER2 positive metastatic breast cancer. So let's take a journey through our breast cancer. We know that breast cancer comes in different subtypes. Some of you have been diagnosed with metastatic estrogen receptor positive, or I call it estrogen responsive breast cancer. Some of you have been diagnosed with triple negative breast cancer, and some of you have been diagnosed with HER2 enriched or HER2 positive breast cancer. So I think the biggest landmark study was in metastatic HER2 positive breast cancer. And this was a study that looked at second line treatment. And remember that when we talk about lines of treatment, we talk about when you're first diagnosed, it's considered first line. If the tumors or cancers start progressing on first line, we switch it to a second line treatment. And we know that it's really antibody driven, right?
That's in the metastatic setting, right? That's first line
metastatic
Okay.
HER2 positive breast cancer. I'm going to take a little bit in terms of the metastatic because we hear a lot about clinical trials and research not happening in metastatic. There is a lot of research happening in metastatic because all of these novel therapies, we test them in the metastatic setting typically first and see if we have a signal. And then we start moving it earlier on in the lines of therapy to early breast cancer, because obviously we really want to cure this disease. HER2 positive breast cancer, really, we knew about HER2 positive over really 30 years ago now, when that HER2 transmembrane protein was identified and then antibodies started being treated. So we really target that type of breast cancer. There are these new smart bombs, we call them, these new antibody drug conjugates coming on the market. And I'll talk to you about the triple negative breast cancer smart bomb. So this smart bomb is, the old one is known as TDM1 or Kadcyla, if any of you have been treated with that. So this is for metastatic HER2 positive breast cancer. And what this is, it's an antibody and onto its attached chemotherapy. So it's like a Trojan horse. It sneaks in, it attaches itself to a HER2 overexpressing breast cancer cell. It gets taken up by that HER2 overexpressing breast cancer cell, and then it releases the bomb inside. And so the cell dies. And so that is how these antibody drug conjugates work. The newer ones, and this is where this data comes in that I'm talking about, this new data. These newer ones, those are these newer antibody drug conjugates. They once again go into the cell, they get cleaved and the smart bomb comes out, but then that smart bomb diffuses out. And so breast cancers are just not one type of breast cancer that builds and is spread everywhere. It's these cancer cells start mutating sometimes. And so it's called a heterogeneous. Homo is the same type of cell. Heterogeneous is a mix of different cancer cells. So some might be low HER2 expressing, even though we are treating you for HER2 overexpressing breast cancer, some might be low HER2 expressing in that milieu of the tumor, right? In that tumor itself. So these newer smart bombs, they go in and they actually then leach out this cytotoxic chemo into the surrounding tumor. So it's called a bystander effect. And so we're having better outcomes with these newer targets. So this is a drug called trastuzumab deruxtecan, and it has shown such great promise. So it was a head-to-head trial. So standard of care in second-line metastatic HER2 overexpressing breast cancer is a drug called TDM1 or Kadcyla. So it was TDM1 versus TDXD, right? Trastuzumab deruxtecan. And it was unbelievable that the TDXD provided a 72% relative risk reduction in progression. 72%. We've never seen this. The curve separated right off. So now we're getting better and better therapies. So guess what? This TDXD is moving up the lines. And now we're going to move it into the curative setting. But what we're seeing in HER2 overexpressing breast cancer is that women are surviving way longer. We're looking at over kind of 60 months of median survival. So 50% of our patients are alive beyond 5 years. And we have many women who are alive years. Now we're asking the question, should we stop? Should we stop this maintenance treatment? So that's one really outstanding great drug It does have some toxicities. It can have a serious lung toxicity where you might have shortness of breath and cough. So we have to watch our patients quite carefully. So that was one. The other really interesting data that came out for metastatic HER2, so I'm going to continue on HER2, is a combination called tucatinib, which is a pill, capecitabine, which is a chemo, it's a pill. Some of you have been on capecitabine, known as Xeloda. And the other one is trastuzumab, or known as Herceptin. So three drugs, 2 are pills, one is an intravenous infusion, the trastuzumab. And what we saw with this combination is that we learned that a lot of HER2 overexpressing women can develop brain metastases. So cancer in the brain, 50% of our HER2 metastatic breast cancer patients, 50 can develop brain metastases. This novel combination of the pill, the capecitabine chemo pill, so tucatinib, which is a HER2 targeted pill, capecitabine, which is a generic chemo pill, plus the Herceptin or the trastuzumab, the HER2 antibody. The combination of these 3 affected the brain. It shrunk active brain metastases, and it had an incredible response in heavily pretreated HER2 positive breast cancer patients, metastatic. So once again, guess what? We're going to start moving these treatments earlier on, and we continue to have a armamentarium. We have lots of options for metastatic HER2 overexpressing breast cancer patients, and we're going to see that survival bar increase and improve. So that's really HER2 positive metastatic breast cancer. We're also, as I said, we've got clinical trials in progress, moving these into the earlier stage settings, because we continue to try to improve our outcomes in women who are diagnosed with early HER2 positive breast cancer. And remember that we're giving more and more upfront treatment, pre-surgery, for HER2 positive breast cancer.
And I think that's where that shared decision-making comes in, where if we can help our patient community understand, what do these treatments mean for long-term, people have to make decisions how aggressively to treat up front to try to achieve, certain goals. So I'm imagining it's going to take a lot more for oncologists to have these kind of conversations with their patients. Yeah.
So kind of so also I must say, so this TDXT, this novel smart bomb I was talking about earlier, we are also we have one clinical trial at actually Mount Sinai. We have them at Princess Margaret. We have them at many sites in Canada. This is a study looking at something known as HER2 low. So you can be considered triple negative. So ER, so your tumor doesn't express estrogen, which most 75% of tumors do, doesn't express progesterone, and it's HER2 negative by our criteria. But there might be a little bit of expression called 1+, right? Or 2+, and it's still kind of negative when we look at copy number, genetic copy number. We're doing a clinical trial to look at HER2, low HER2 expression, mostly right now in the estrogen-driven population, to see if this TDXT, this new smart bomb, is effective. So stay tuned, because we're going to have more and more interesting data coming out.
Wow, this is interesting because our community really does identify by their subtype often, where someone's like, I'm a triple negative thriver, I've got HER2 positive. Now we're seeing that there's maybe some in-betweenness, and we're
learning more and more.
We're also learning that tumors can change in a metastatic setting.
Yeah.
So that's
so we tend to, depends on when you were diagnosed initially, and it depends on when the tumor comes back. So if it metastasizes, we try to get a biopsy, and we get a biopsy just to see what does that tumor profile look like? What are the biomarkers? How can we treat that tumor the best way? How can we treat you the best way? So we'll look at the estrogen receptor, progesterone, HER2, and now we have other targets we're kind of looking at, something known as PIK3C alpha. This is just another, we look at how that cell divides, we look at the at the pathway inside the cells. We're looking at different gene alterations. We're looking at the estrogen receptor. Is that receptor mutated? It's called ESR1 mutation. So we are really looking at different drivers within the cell, and it continues to evolve. And we have molecular targets that we are studying. So we've got clinical trials ongoing right now that are trying to address that. So when we move forward, there's so much to talk about, because this has been the year of breast cancer. If you look at any type of cancer, this has been a year of breast cancer.
What about triple negative? Because that's the one we always felt there wasn't a targeted treatment for.
So let's move to triple negative breast cancer. Let's continue with the smart bomb approach.
Okay.
So there's a new drug called Trodelvy, but it's known as sacituzumab govitecan. Say that 5 times quickly. We'll call it SG for short. So again, smart bomb, okay? It's an antibody that attaches itself to something called TROP1, which is overexpressed theoretically in triple negative breast cancer. And this antibody has about 7.5 chemotherapies. And we have the mechanism of this chemotherapy because it's called irinotecan. We use it in a lot of GI cancers, which I treat as well. So this smart bomb has shown, again, in metastatic triple negative breast cancer, significant improvements in progression-free survival. So ensuring, looking at this tumor and ensuring it doesn't progress. Significant, almost a 45% relative risk reduction. And once again, you see those curves split incredibly, both in overall survival and progression-free survival. What do these things mean? Women are surviving. And this was in heavily pretreated, so 2nd or 3rd line metastatic triple negative breast cancer, that we have this strong signal of effect. And so finally, September 27th, so a month ago, Health Canada approved this drug in Canada. So they got notice of compliance that we can actually get this drug. So our biggest issue now is getting this drug to our patients.
Yeah, we did a survey. We put in the submission. Rethink's been putting in submissions for all these amazing treatments.
This is a great drug. This is a great drug, and we can't wait to get it into start treating our patients with it.
There's been demand for it from the community for sure. So exciting that it's finally coming. What else is happening in triple negative? So
you've heard about immunotherapy. You've heard the buzz of immunotherapy. What is immunotherapy? Well, these are, again, antibody therapies. So intravenous through the vein. So an infusion therapy where we try to activate your immune cells to kill the tumor. We haven't had a lot of success in breast cancer, but triple negative breast cancer seems to have a signal. And we did have about 3 years ago, almost 4 years ago now, the first signal. It was a drug called atezolizumab. It was used with a drug called nab-paclitaxel chemotherapy, and this showed promise. But we kind of now are thinking there must be a signal, and that signal is a target known as PDL1. And you might hear that in the buzz. PDL1 is really just the ligand. We're looking at whether or not there is expression on the breast cancer cells. We are interested in something called a combined positive score, CPS. Why? Because we're looking not only at the tumor, but we're looking at the immune microenvironment around that tumor. And we want to see whether or not we have any signal. So new data came out, okay? It was known as Keynote 355. It looked at pembrolizumab, which is it's an antibody that is an immunotherapy antibody in combination with chemotherapy. And when we enriched and looked at patients who had the CPS, score, that there was a great signal that this drug was effective, and is a CPS score greater than 10. So now we have to get our pathologists again on board. It gets a bit complex. We get pathologists to score these tumors, which is another issue. And then we have to get this drug because we have survival. And this is first line. So when you're newly diagnosed with metastatic triple negative breast cancer, this is how we're going to treat. And it was either treated with intravenous paclitaxel, intravenous nab-paclitaxel, which is a different type of paclitaxel, or intravenous gemcitabine carboplatin, which some of you might have received. And when we looked at the combination with pembrolizumab, it was quite effective. So that's exciting.
Wow.
Very exciting. But
you've got more.
Now let's talk. Let's talk about moving this into the early stage setting triple negative breast cancer, because we want to cure cancer. We want to cure breast cancer. So triple negative breast cancer, many triple negative breast cancer, when we have a diagnosis and we're seeing that patient for the first time, and she has her breast cancer in the breast, maybe some lymph nodes involved in the armpit, we want to give preoperative, so before surgery chemo, because we want to shrink that down. And we know, and the same for HER2 positive, okay? Estrogen receptor driven is a different story, and we'll talk about that because we've got new therapy as well for that. So triple negative breast cancer, when it's early and we're talking about cure, we give preoperative chemo. And guess what? There was data presented, it's called Keynote 522, and it was presented that we should give this immunotherapy up front, regardless about this PD-L1 status.
So anyone with triple negative breast cancer.
Anyone, all comers with triple negative breast cancer as a curative, is that we can treat these, and it's effective, giving them pembrolizumab with chemotherapy.
Wow. So
it's very different. Early triple negative breast cancer is different than metastatic triple negative breast cancer. And we're thinking, why is there a difference here? There's a different immune biology when it's early versus metastatic, there's a different signal. So it was effective for all comers. Okay, it was effective for all comers. And new data, it's called the Brightness trial. So let's build on this story. What is the best treatment we can provide preoperatively? We give chemo, and we give lots of chemo, because why? We want to get rid of that tumor permanently. It's called a pathological complete response. What does that mean? Is that if you have a 4-centimeter tumor sitting in your breast, you have 2 lymph nodes that look positive, they've been sampled. We give you the preoperative treatment. We'll talk about what that is, a preoperative chemo and now pembro. We now see over a 60% opportunity, 60% of achieving a pathological complete response. 60% tumor disappears, melts away. So when you have your surgery, there's no tumor there. Why is that important? Because that tells us you have a great survival. And so this Keynote 522 showed that it's called Taxol carboplatin, 2 chemos, and then followed by adriamycin cyclophosphamide. These are standard chemos. We're just now adding a platinum to the combination. Plus now pembrolizumab, that immunotherapy. Women are alive, if they get a PCR, 95% at 3 years. Why is 3 years a magic number in triple negative breast cancer? Because if you're alive, can you imagine? We're basically curing. If you're alive at 3 years, and you get a pathological complete response, your chances of surviving are excellent. Because triple negative breast cancer, if it doesn't come back after 3 to 5 years, it's probably never going to come back.
That was, wow.
This is so important and groundbreaking for us. So now we're pushing to get pembrolizumab, right? So Health Canada has to approve it for early triple negative breast cancer. And now we're getting the word out, please add a platinum, carboplatin, to this treatment regimen, because we're seeing 10% improvement in this pathological complete response. So extremely important in how we start treating early triple negative breast cancer. So some new stuff as well. It's important. In May of this year, Ontario, so we're trying to push this across Canada, but Cancer Care Ontario, now known as Ontario Health,
Yes.
changes criteria for genetic testing. So any woman diagnosed with breast cancer under the age of 45 gets a panel genetic test. And if you have triple negative breast cancer, if you're diagnosed with triple negative breast cancer, you get a panel test under the age of 60. So we have certainly made improvements. And why is this important? It's important because if a woman has a mutation, some kind of born with some kind of germline mutation, or even develops a sporadic mutation, germline mutations, we now have effective therapies. So the germline BRCA1 or germline BRCA2, or another one known as ATM, another one known as PALB2, another one known as CHEK2, is that we can use these PARP inhibitors. One is known as olaparib. So at ASCO, the Olympia trial was read out, and this is with women with germline, those 5 mutations, women with triple negative breast cancer who did not get a PCR, and they were then randomized to receive this olaparib, this pill, okay, for a year versus placebo, so a sugar pill. And once again, it was like a 45% relative risk reduction.
Wow.
Okay.
Wow.
In invasive disease-free survival. So as you can see, we continue to move the envelope, improve outcomes. And this was for also estrogen receptor positive and for triple negative breast cancer. So these high risk breast cancers, olaparib for a year was significantly beneficial in improving outcomes and survival.
This is why Rethink has been advocating for equal access or equal funding for take-home cancer treatments, because a lot of the new treatments are pills, it seems like. Yeah. Wow. I'm looking at some of the questions. I know there's probably a little bit more you want to cover, but I think we actually covered off the first question. It says, given that triple negative has no targeted therapy, is there anything promising in terms of early stage? They're asking about triple negative vaccines or other treatments to reduce recurrence. So I think you answered about the new treatments, but what about vaccines? Is that a question you get a lot?
Vaccines are coming out there. They're not prime time in Canada, and they're not yet prime time even for clinical trials, but there are parts in Germany and the US that are studying vaccines. So they'll take your tumor and they'll try to build a vaccine against your tumor.
Here's another question that we've been reading about ESR1. So what does it mean if a mutation or amplification is oncogenetic, or amplification the same as a mutation? I guess, is amplification the same as a mutation? I'm thinking about the ESR1 mutation in metastatic setting.
Yeah, so it's not amplification, it's actually point mutation. So ESR1 mutations makes it basically less effective to certain therapies, such as tamoxifen, if you've heard, or aromatase inhibitors. And so there's been evidence that the injection fulvestrant, which is a selective estrogen receptor downregulator, has more of an effect when there's an ESR1 mutation. And now there's a lot of these oral, so the fulvestrant is an intramuscular bump shot. You need to get one in each bump. So an intramuscular can be painful. Now there's these pill, so take-home medication, oral SERDs are being investigated to see if they're effective. So obviously the oral SERDs are being used with the CDK4/6 inhibitors. They're being put together, they're being studied. So it's quite exciting right now.
Yeah, I mean, having been working at Rethink for 20 years and just, you know, we've been pushing, we want to see longer, better outcomes for the metastatic community. And it does feel, with that advent of CDK4/6 inhibitors, this is just anecdotal, me like working with the community, it feels like things are really improving in terms of.
They're significantly improving. I mean, when you look at the last, I'd say 10 years, survivals it's incredible. Like we're looking at 60+ months. So half of our patients are alive at 5 years. I know it's always a challenge, but we want to move that. We want to cure the incurable. And we've had some metastatic HER2 breast cancer patients, to be honest, that have been cured. I have women in my practice over 10 years, and doing fine. And if a brain metastases occurs, well, we go after it. We remove it, we radiate it, we do everything we can. And women still have pretty good quality of life. And that's what's important for us.
Absolutely. I see someone picking up on your use of the word smart bomb, asking a question. Would you recommend changing the course of treatment for a smart bomb drug during a course of treatment, or wait until there is progression first? What are the risks, benefits to each? I guess as we're hearing about these new treatments, and maybe you're already starting a plan, but the new one's available, do you switch, or do you?
No, we all say if something is working, you stay with it. You stay with it, because you never know, you might get an amazing response, and then you hold that, right? You hold that in your back pocket for when you need it on progression. So we don't switch, when something is working well.
A couple of people are asking about, these expressions, like, is there a way to test for TROP2 expression? Someone else asked, do you see Pembro being offered as a second or third line in the future for metastatic triple negative breast cancer? And is PD-L1 testing readily available in Canada? So are these tests just happening automatically behind the scenes? Like patients? No.
PD-L1 is not standard of care yet. So remember, when these drugs come out, it's called a companion diagnostic. We still in Canada have issues in terms of putting these drugs forward, because there's many that have a test associated with it. So we had such great outcomes with HER2, so testing for HER2 became standard of care. But again, there was a big push, but that still takes time. You have to validate, so you have to do at least 100 cases. You have to validate it, make sure that the lab is doing well. And you really want it done at your site. You don't want to have to wait 2 to 3 or 4 or 5 weeks because your tumor is in, North York General, and then it's being tested at Princess Margaret or Mount Sinai, and you have to wait for that to go back and forth. You really want it centrally tested. Now, PD-L1 testing is out there. We've been testing it for lung cancer. We've been, it's been kind of, but they call it a TPS4. And they grade it a bit differently, but it's out there. So it's not novel testing. We just have to ensure that our breast pathologists start testing it. But right now it's like, well, the drug is not available, right? It's not Health Canada yet approved. And so it's all going to take time and come forward. TROP2, so they actually, at ESMO, they showed the data with sacituzumab govitecan and TROP2 expression. Low TROP2 expression, fortunately, is only about 16% of triple negative breast cancer. So majority, and still there was a signal. So it's really kind of independent of TROP2 expression. I must say also the pembrolizumab was independent. So the early stage, when I say it's given with chemo and pembrolizumab, regardless of PD-L1 status, it was independent of BRCA status. So both germline, so if you have a germline BRCA mutation versus non, pembrolizumab was still quite effective.
Wow. One more question, and then I'll ask you something. Any new treatments for hormone positive breast cancer, just still tamoxifen and OSAI?
Okay, so yes, there were some genomic aids that were coming out. So you've heard of Oncotype, you might have heard of Mammaprint, you might have heard of EndoPredict, and then in Vancouver and BC, they do a lot of Prosigna. So these are all these genomic aids. What it means, it takes a piece of your tumor, it runs all these genes and does this statistical analysis, and it spits out a recurrence score. It tells you what's your risk of, what's the benefit of chemotherapy, what's the benefit of anti-estrogen therapy, and it's a decision aid. So there's one called Mammaprint, is made by Agendia. It has a blueprint component. So we've been using this more and more in our women who have ER positive breast cancer. We want to give preoperative chemo to. So these are the big tumors, the lymph node involvement, the high risk that we worry about. And so we've been kind of doing this blueprint, and it kind of tells us whether or not how this tumor may behave. So it's called the luminal A. So it gives us the subgroups. Luminal A, which is a slow growing, probably won't benefit from chemo, but anti-estrogen therapy. luminal B, which would benefit from chemo, triple negative, so a basal-like, maybe we'll add a platinum to that. And HER2 enriched, oh, maybe we have to somehow relook at it and see whether or not we need to add an anti-HER2 targeted therapy. So it's very interesting. We're kind of moving that bar
Wow.
in terms of how we're looking at that tumor before we actually treat it.
And just remind us in Canada, so you have access to MammaPrint at your hospital. Is that something that
MammaPrint standard of care? So you
it
can
is?
get MammaPrint.
Okay.
You can get MammaPrint. MammaPrint is the same as Oncotype and EndoPredict. You can get all these genomic aids. Cancer Care Ontario Health funds it.
Someone asked about a Signatera test, which I actually hadn't heard of. I'd heard of all the other ones you just mentioned. Signatera.
I've not heard of it.
Okay.
So it might be a next-gen sequencing, which basically is really profiling the tumor.
Okay.
And that, unfortunately, at this time for breast cancer is not standard of care. So you probably heard of Foundation One. Yeah, there's all these different, in the United States, there's all these different types of next-gen sequencing. And now all of the institutions are up and running. So at Sinai, we'll be running a OncoGX 500 panel. And then we also are going to be embarking on liquid biopsies. And this is also Princess Margaret has it, Sunnybrook has it. William Osler is doing a smaller panel. So the nice thing is that eventually I'm hoping Cancer Care Ontario starts funding it. We can actually profile patients with metastatic breast cancer. So we can look at all of these targets, right? And then it kind of allows for drug discovery, allows us for treatment, and it, can guide our therapies and how we sequence. And we can kind of tell a patient, what's next.
So much like precision medicine advancement.
That's truly precision medicine. Yeah.
I do see someone asking about olaparib. My understanding with olaparib is that is only for metastatic disease. Is that correct, or can it be used with early disease?
So it is. So they're trying to get it funded for early, but it can be used based on the Olympia trial. It can be used for early stage breast cancer if there's a germline mutation, and it's for the criteria that were studied in Olympia. So that was if there was residual disease with preoperative ER positive, HER2 negative breast cancer, or triple negative breast cancer.
Because that's how the clinical trial was set up.
That's,
so that's what it can be used
how
for.
we would use it. We're not going to go, and develop our own criteria. Really, it's the criteria. So speak to your oncologist. If you're aware that you have a germline BRCA mutation. And if you're
and that Jen, who asked that question, is letting me know that Signatera is looking at levels of circulating tumor cells.
So circulating tumor DNA right now, there is, it's really in research, it's not prime time. And really, I think the best is looking at circulating tumor cells, as opposed to circulating DNA. But we do try to risk stratify. So if there's circulating tumor DNA that is noted in your blood and you're cured, then you have a risk of recurrence. Think about it. You've got this, you've got cancer cells somewhere floating in your blood that can attach themselves onto bone, onto liver, onto anything. So this is where we want clearance. So there is clinical trial and clinical research ongoing to look at if there's presence of circulating tumor cells or circulating tumor DNA. So circulating tumor DNA is cancer cells that have shed their insides as they die off or as they proliferate and grow. So sometimes if you have not a lot of cancer, you're not going to be positive for circulating tumor DNA. And from that, then we try to do next-gen sequencing. So we try to do that precision medicine if we have enough circulating tumor DNA to do it on. But there still can be a bit of discordance between your circulating tumor DNA and your say liver biopsy or your type of biopsy.
Oh, wow. I'm like looking at all these questions. I know you have more to say too. There is a question that I think is relevant because you're the expert on this. How badly do OS and AI affect your heart? I'm 42. And I know you know a lot of, that's one of your passion areas is cardiotoxicity. So I don't know if you want to answer that now or you want to finish talking about other new things that are that
Well, I
you
think
wanna
it's
share?
important because this comes on along, comes
Along with
forward
the
from
innovation maybe comes some of these
Yeah,
issues, or?
so there was a meta-analysis looking at these AIs, aromatase inhibitors, such as letrozole, anastrozole, exemestane, and the risk of having a cardiac event. Now, I don't think it doesn't directly affect the heart, but I think it affects your life. So you can have high cholesterol, you can have weight gain as you age. It doesn't lead to hypertension, high blood pressure. But if you think about all of the kind of side effects, and as we get older, and maybe if there's weight gain or menopause, low estrogen state, these can affect. So it's really multifactorial in the sense that it increases your risk factors for developing cardiac disease. So it's not a direct cause of heart disease. As we know, Herceptin or trastuzumab can affect the heart.
Okay.
That's why we'll monitor the heart. But this is not a direct effect on the heart. It's kind of indirect by weight gain, high cholesterol. It's the risk, the modifiable risk factors.
Okay. I see someone asking, any new treatments for metastatic ER positive, HER2 negative breast cancer?
Yes. So let's move to ER positive, HER2 negative breast cancer.
Okay.
So there was a trial called Monarch E. We participated in it. And this trial was like the Butterfly Monarch. And this was using now, remember we talked about what we use in the metastatic setting, we move it earlier on.
Yeah.
So using one of the CDK4/6 inhibitors, such as abemaciclib, and it moved it into early stage setting. And so this is high risk breast cancer. So large tumors, rapidly proliferating, called Ki-67, over 20%, which we don't actually do in Canada routinely, but also more than 4 lymph nodes involved. Okay. So very high risk breast cancer. And patients were put on abemaciclib, and what it showed was that at a 3-year, and they just showed some updated survival data, that the curves continue to split. So abemaciclib is improving, again, their survival of invasive disease-free survival of women who are taking abemaciclib. So
but is that the early setting, that study?
Early setting.
Okay.
So these are lymph node positive, high or large tumors, high risk, ER positive. So abemaciclib is given with anti-estrogen therapy. And what we've also noticed is that women with high risk breast cancer, ER positive, HER2 negative, early, but high risk, like lymph node involvement, large tumors, that if you're premenopausal, we know that shutting down that estrogen signal in your body, that is shutting down the ovaries, so ovarian function suppression, and switching you to an aromatase inhibitor. And some of we moved to exemestane because you have less joint aches and pains, known as aromacin. That in itself is significant and really improves outcomes with women. So what we're looking at is making you postmenopausal, unfortunately, because there are side effects associated with it. We know about that. But postmenopausal, and then you add abemaciclib, and hopefully we have better outcomes. So it's, again, a short period of treatment of 2 years, and then you hopefully get improvements.
There were quite a few questions that came in advance that were what I would call like just, obviously so many people with the more aggressive breast cancers and diagnosed young are wanting to do whatever they can to prevent recurrence. And there's a couple questions that I thought I'd share. So it says, if trace cells are found in the sentinel lymph node, but it is deemed to be node negative, is it recommended to have a more aggressive treatment plan, such as axillary node dissection, axillary irradiation, and or chemotherapy?
Sorry, it's or?
Yeah, it says if trace cells are found in the sentinel lymph nodes, but it is deemed to be node negative, is it recommended to have more aggressive treatment plan? So then what they're categorizing as a more aggressive treatment plan is axillary node dissection, irradiation, and or chemotherapy.
Yeah, so it depends. It always depends on the size of the tumor. It depends on the grade of the tumor. It depends how estrogen receptor positive it is. And it depends on the lymph node status. So we discuss these cases at our tumor boards. So if there's only isolated tumor cells, it is considered node negative with ITCs. If you're really young, you'll find that your treating team tends to be a little bit more aggressive. We don't necessarily go back and do remove more lymph nodes if it's like one, 0, 2 were taken out and 1 had ITCs. We stop at that, but you might have, because the radiation that you'll get might be into the level 1. So you'll get into level 1 lymph nodes, which is typically your sentinel lymph nodes. So it's complex. We spend a lot of time discussing cases. We spend a lot of time discussing what the best treatment plan is. But we're not going to go in and take out more lymph nodes if we don't need to. We're not going to provide more radiation to the armpit if we don't need to, because your risk of lymphedema significantly increases. Like you have a 20 to 25% risk of developing lymphedema. And please be careful. If you've had those lymph nodes removed and radiated, make sure you wear a sleeve. Make sure you get fitted for a lymphedema sleeve. And if you can't, just go to the dollar store, buy those tensors. I tell my patients, wrap it all the way up to here. And if you fly anywhere, you are at risk of developing lymphedema. So please wear your tensor before you fly, the day before, the day of, the day after, just to move that fluid and keep it, tight. Because
always, or is that just in the recovery phase?
I would do that every time I fly. If you've had your armpit, if you've had your axilla radiated, and you've had lymph nodes removed.
Okay. Another question, do you recommend extending hormone therapy to 10 years for triple positive breast cancer?
So that's a good question. There was a study that was read out at ESMO, and I have to say it because it was an Italian study, and it's Gruppo Italiano Mammalia, which was the GIM study. And what they did was they compared really 5 years versus kind of the 7 versus 10 years. And 7 years is good. 7 years is good. Now, a lot of them say, I'm doing really well with anti-estrogen therapy. Can I use it for 10 years? Well, it depends what your risk is, right? New data was a little bit confusing. That this MammaPrint data came out is a little bit confusing because what they notice is that maybe the women who have kind of the slow growing ER positive, the really estrogen receptive, or these anti-estrogen medications such as tamoxifen or AIs work so well, maybe these are the women that should be on treatment for much longer, 10 to 15 years. But when your risk of recurrence is so low, really how much benefit are you getting when there's still some toxicities, right? Remember that if you're doing well with an aromatase inhibitor, sure, and your risk is high, I would probably push longer than 5 years. But if your risk is low, we tend to stop at 5 years. And you get monitored. You have a mammogram every year. If you have breasts, you have a mammogram every year.
That reminds me of another question I saw in advance. Should we continue annual mammograms after bilateral mastectomy and reconstruction?
No,
because there's no breast tissue.
Yeah, there's no role for it.
No.
We don't want that silicone implant squished.
No, and rupturing. I'm looking at some of these questions, and I know it's so helpful to have community for people with breast cancer and young people especially. Everyone's got different treatments. People can share kind of, I'm the same subtype, what treatment are you on? But then you can also start to question, am I on the right treatment? Oh, you're on this, you're on that. So I know that's an issue that people grapple with. And I'm just seeing someone, asking triple negative breast cancer, ACT with carbo, PCR. So I think that means they achieved PCR. I'm not sure. Bilateral mastectomy. Should I have done Xeloda? So kind of having those, did I do the right thing? Should I have done more?
Yeah, no. So Xeloda, remember this was in an Asian study only. So it was Japan and South Korea that participate in the study. So it's a truly Asian study. And what we don't know whether or not, the Cape Cytidine, well, we do know that 5-FU, which is Cape Cytidine Xylota, can behave differently. And this was really effective. About 30% of that population, of that study population, were triple negative breast cancer patients. So 30% only, 70% were not. But there was a very strong signal of survival, and that changed how we practice. And it was only, so we only give capecitabine in women whose tumors are not completely gone. So when there's residual disease at surgery. What does that mean? You got your chemotherapy up front, you had your surgery, the tumor came out, but in the tumor pathology specimen, there was, instead of a 5-centimeter tumor that we saw on your MRI or mammogram or ultrasound, it's now 0.5, right? So 90% of the tumor was killed by the chemo, but there's still some tumor there. Yeah. So residual disease, it's called residual disease, or you might have lymph node involvement. Those are the patients that we give 8 cycles, so 8 treatments. They're one treatment's every 3 weeks. So 24 weeks, which is 6 months of chemo after your surgery. And that was for triple negative breast cancer only. Okay. We don't have questions about, what about if there's a BRCA mutation? Should we be giving olaparib? Should we be giving olaparib and capecitabine? What about if you got pembro and you don't have a PCR? Should we be doing pembro, capecitabine, olaparib? So all of these questions are not answered. There are some studies outgoing with like pembro and olaparib, durvalumab, which is another monoclonal antibody in IO, and olaparib. So we are still going to figure that out. But no, if you got a PCR, you don't need to have any post-operative therapy in terms of pills.
All right. Oh my gosh, so many questions. And I know it's already 5 to 8. So maybe we'll try to get through a few more, unless there's something that you feel we haven't covered in terms of new data and new exciting things you wanted to share. I know we covered a lot of the new trials. Someone saying, I was diagnosed with inflammatory breast cancer in my right breast at age 36 in 2019-2020. Biopsy results revealed it was hormone positive. I was on chemo, AC4-PAC12. I had bilateral mastectomy with axillary lymph node dissection. I was also tested positive for PALB2 genetic mutation. My mastectomy results revealed that there was up to 10% of residual disease, and 5 out of 11 of my lymph nodes had cancer. So 10% of residual disease was hormone negative, and the lymph node involvement was hormone positive. I had radiation therapy, and I'm currently on Zoladex and letrozole for 5 to 10 years. She's constantly worrying about cancer recurring and metastasis. Do I need more treatments?
Well, you'd have been a candidate for the Olympia trial. So PALB2 was part of patients got olaparib, because you would have residual disease. It was a CPS EG score, and you would have at 3 or greater. And the fact that you had lymph nodes that were ER positive, you would have been a candidate for olaparib. But right now, you are over a year out from your treatment. You're going to be on the Zoladex and letrozole, which is great, because a big part of it is, a big part of that is the fact that you have estrogen blockade, right, with the Zoladex. That's putting your ovaries to sleep. You also would have been eligible for abemaciclib. So abemaciclib, as I talked to you about, the CDK4/6 inhibitor, which showed a significant reduction in progression, and there could have been an opportunity to go on abemaciclib.
Okay. Is there a benefit of continuing on ovarian suppression, Zoladex, while on capecitabine or any chemo when both hormone positive and triple negative breast cancer are present?
So if you've got 2 different subtypes, you're really treating with the ovarian function suppression, you're treating the hormone receptor positive, right? The one that's driven by estrogen. The triple negative has no effect with respect to shutting down your ovaries because the estrogen is not driven by estrogen.
How common is that to have these like two?
It's not common. It's not common. I hope you've had genetic testing done, panel testing, because when you have 2 breast cancers and triple negative under the age of 60, you're eligible for genetic testing. So if any of you have been diagnosed at the age of 40 or 41, 42, and you're like 3 or 4 years out, I'd go back and ask to be retested because today's criteria, you would be eligible. You would have been eligible for panel testing. Now, the one thing that we do is for fertility preservation. For our young women, we actually, it was called the POEM study. I shut the ovaries down with Zoladex. And I shut them down just to put them to sleep so the chemotherapy doesn't attack the ovaries. And so and I do that for triple negative breast cancer patients as well. So I make sure that we kind of protect those ovaries because actually there's a 21% successful rate in pregnancy and live births. And so we try to do all this just to improve the pregnancy outcomes after. And some women try to get pregnant afterwards. We did do a study called the positive trial, and that will read out in terms of telling us if we interrupt tamoxifen after 2 to 3 years, and a woman tries to get pregnant, who has obviously estrogen receptor positive, a history of estrogen receptor positive breast cancer. And then she gets pregnant, has a pregnancy, has a hopefully very nice, lovely delivery of healthy children or child. And then we put them back on tamoxifen. So we once again restart the anti-estrogen after the baby is born. I had twins, so I'm always thinking it's babies. And so that information we'll have in the future to know, is there a risk of breast cancer recurrence? We always worry if it's high risk estrogen driven breast cancer. We always worry as treating oncologists that breast cancer can come back when you get pregnant because the estrogen load in your body goes up, 10,000-fold high. So if you have a sleeper cancer cell somewhere, it might activate it.
These are the decisions.
You don't have data right now.
Yeah, these are the decisions young women grapple with.
It's all anecdotal. And if there's a high risk of breast cancer, there's a high risk of breast cancer, regardless of pregnancy or not. And we don't want to, light that match. Lighting that match might be getting pregnant and having, very high estrogen counts in your body.
Yeah, it's just another reason why it's a difficult stage of life to be facing breast cancer.
We recognize that. And many of my patients have had surrogates. So, in terms of family planning, if they can, and it can be very expensive. Anyways, we need to do
that. Could be another topic.
That's another topic. We certainly need to do more. And another thing I want to put forward is sexual health. So ensuring that, your sexual health, that, now we're embarking on a couple of studies. We're doing at Sinai. We have a SheCan clinic, a sexual health and breast cancer clinic. Just by, working with our menopause experts, just to improving the side effects of all of these treatments that we're giving you, putting many of you in early menopause for the sake of not getting breast cancer again. But, obviously we want to support you through that journey.
Yeah. I mean, a kind of semi-related question just about, managing side effects from all these treatments. Someone asked, is it okay to take a 6-week break from tamoxifen if you are having side effects?
Yeah. I mean, taking, I typically say 4 weeks. I don't know, 4 or 6 weeks, there's no magic number. Yeah. But absolutely, we give patients breaks. And we find that when they restart it, it's a lot better. So a trick with tamoxifen is split the dose. Take your little pill, cut it in half, and take 10 milligrams in the morning, 10 milligrams at night. Okay. And if you're having any anxiety or depression, that tends to improve it. So, you can play around. You can play around taking it in the morning or taking it at night. I tell most of my patients, start your anti-estrogen therapy pills at night. Because if you're getting hot flashes, hopefully you sleep through them. Then you say, oh my God, they're waking me up. Well, then let's switch to the morning. We've got ways, we've got little tricks here and there. We've got also supportive meds if you're getting a lot of hot flashes. We've got medication for that. And, I know you get medication, type of medication, type of medication, but we want you to stay on your cancer therapy. We don't want this breast cancer to come back. So we really have to work together to try to make it work for you.
Someone asked, how do you know if you have residual disease? Is that not reported on your
not
pathology?
residual disease all over your body. It's what came out. So it's in your breast pathology it's in your pathology notes.
Yeah. So that means like after surgery, you had the chemo before surgery.
Yeah.
They removed the breast tissue and then combed through it and found it didn't get everything.
Yeah, your treatment, it depends what your treatment journey is. Some of you have had surgery up front and then you get your treatment afterwards. That's called adjuvant. If you get your treatment up front, your systemic therapy, that's me. If you see an oncologist before you have surgery, it's called neo or before preoperative therapy. And then we give that to you up front and then you go for surgery. So at surgery, you're going to get a pathology report and your doctor is going to say, it all died, right? All the treatment worked because all the tumor, all the cancer disappeared. That's called pathological complete response. I'll just say, oh, you had 5 lymph nodes taken out. There was cancer in one of them. That's called residual disease.
Okay, thank you. Back to sexual health for a second. Someone asked, is topical vaginal estrogen safe for ER positive MBC to reduce menopausal symptoms?
Yeah, so there's more and more data coming out in terms of topical vaginal estrogen that there's minimal to no systemic absorption, so it doesn't put an increased risk of breast cancer. Okay, so it's safe. Work with your gynecologist or your family doctor. And there's there's estrogel, estrogyne, there's Vagifem, there's all these different ones. There's also a CO2 laser that's been used to kind of build up the lining, so the vaginal lining. So if you're having, difficulty with intercourse, dryness, itchiness, it can go on and on. You certainly can start with just topical estrogen.
Okay. Sorry, we're kind of jumping all over, but the questions are just kind of all over the place. Thank you for ping-ponging with me. I'm going back to a question that I think pertains to, we've got all this exciting new data coming out. We've got, really exciting news in breast cancer. Some people here are asking questions, oh, would I have been eligible for this or that? How do you communicate? Like, what recommendation do you have for our community on communicating to their treating oncologists of saying, I want to know about everything, or am I eligible for this clinical trial? Are there any kind of communication tips that you would recommend?
Well, don't think that, we live in Canada and unfortunately a lot of these clinical trials are not available to us. So for example, the sacituzumab govitecan trial, right? It wasn't, still couldn't get it into Canada. But now we want to get the drug in Canada. So what I'm just saying is that there are clinical trials. It's not always available, and there's like a few sites. So if you live in Toronto, chances are you might have an opportunity. But if you live in Saskatoon, I did that for you, MJ.
Yes.
If you live in Saskatoon, you might not. There might be nobody in Saskatchewan having this clinical trial. Nobody in Manitoba having a clinical trial available.
That's tough.
Of course it's tough. And we obviously you're getting treated with the best treatment, which is standard of care at the time, right? And that's what most of us, and that's how we've treated our patients. That's the best treatment we have, and it's still very, very good in Canada, right? But we're making all these incremental benefits, and we're getting there, right? Yeah. We're getting there. It takes time.
Yeah, and beyond trials, as new treatments are being approved and there's that waiting period, maybe they've been recommended for funding, got a positive recommendation, it's about to be in the hands of patients, and we know the industry will often open up a compassionate access program. So, we
really work with industry.
It's important for the community to know about these new treatments and ask their physician, or is it just we have to trust that the physicians know about all the new treatments, or is it okay to be asking about things?
Yeah, I mean, you're your best advocate. Ask your patient, I ask your doctor, sorry, ask your doctor, hey, I saw this. I saw this
Mhm.
coming out on Health Canada. Can
Mhm.
we get this drug? And then, your doctor might say, well, it's not yet available. There's still no
Mhm.
compassionate. Compassion is coming out. So
Mhm.
we do a lot of meetings. We get the word out. We
Yeah.
do a lot of presentations at meetings. And so, the word does get out. Definitely
Mhm.
the word does get out.
Okay. Someone's
But
been diagnosed.
there's a lot of data, so
It's a lot. It's a
which is
lot
exciting.
a lot to wade through, and feels like there's something for almost every subtype. Is that accurate?
There is, and I can tell you, it's so exciting because we're learning these driving mutations, what's driving that cancer cell, and we're targeting it. And even not like even just targeting the environment of like the
Mhm.
trope2, right? Like who knew this would work? So it's actually very exciting that
Mhm.
we are pushing the envelope. Now sacituzumab govitecan is being used earlier. It's being also used with immunotherapy. So you continue to push that, right? You continue to
Mhm.
push that to
Mhm.
ensure that we cure more and more patients.
Mhm. And the treatment experience and I guess pathways changing in some types. And I see a question here. So is doing surgery first for an initial triple negative breast cancer diagnosis not being done at all anymore? Are we always giving treatment before surgery? The person she's
Yeah.
asking, she said that was the approach in my case, which makes it hard to know is more needed.
Yeah, so it's a very good question. We are recommending for tumors that look around 2 centimeters or greater. For sure, if there's lymph node involvement, we are recommending preoperative treatment. So that is kind of when we look at pathways.
Mhm.
So if you have a small tumor, if you have a 5 millimeter triple negative, we say go straight to surgery. You might not even need any treatment.
Okay.
If you have a 1.5, 1.7 centimeter tumor, this is granularity, right? Are we that good? We're like, but lymph node negative, we sit on the fence. We're like, maybe go directly to surgery,
Mhm.
because then we'll give you treatment afterwards. So it's variable.
Okay.
We don't want to also don't think we don't want to overtreat. We don't want to give you a lot of treatment when your risk of recurrence is small, right?
Mhm.
So you hear
Mhm.
about all these improvements, but these are improvements in many cases of either metastatic or high risk.
Mhm.
So we want to minimize that high risk.
Mhm. Yet not overtreat because of the side effects
Oh, for
and
sure.
quality of
There's
life.
lots of side effects. We know there's lots of side effects.
Yeah. 30 years old, ER/PR positive, 15 lymph nodes removed, breast cancer, had chemo radiation, now on aromatase inhibitors. My doctor has insinuated to consider removal of ovaries because his other clients have. I was shocked, just wondering what benefits I would get from that compared to aromatase inhibitors. 30,
Well,
age 30.
so if you're on an aromatase inhibitor, you have to have your ovaries shut down. So you should be on Zoladex or whatever LHRH agonist. You cannot be an aromatase inhibitor and be premenopausal.
Mhm.
So typically it's either monthly injections, and then sometimes we move to Q3 monthly injections, so a bigger dose. So you have to have your ovaries suppressed. So they're either suppressed chemically with the injection I talked about, or if you're not going to have any children, so if you're past your childbearing years, then you can get your ovaries taken out.
And is that usually the deciding factor? If you are wanting to have children, you will obviously won't do the surgery, or would there be a case where it's not one or the other depending on your own personal goals? Would it depend on the way your cancer is behaving, whether you do the surgery or shut it
Well, it
down
depends how high risk.
chemically?
So if you have 15 lymph nodes involved,
Mhm.
think about it. That's cancer in 15. So think about what lymph node
It's
means.
hard to understand that the note says 15 lymph nodes removed and then
Okay, so
comma breast cancer. So it doesn't say that it's
okay,
in 15.
but think about when I talk to my patients for the first time. So I go through the whole kind of
Mhm.
biology 101 of cancer and what the
Yeah.
breast cancer, what your breast cancer means. Think about it. if your breast cancer has moved to the lymph nodes, those are the first organs outside of the breast that cancer cells have now moved out. And that's why it risk stratifies, because we know those cancer cells have moved outside of the breast. So guess what? They can move elsewhere. And that's what we worry about. We worry about them moving to the bone, to the brain, to the liver, to the lung, anywhere else. Right? So this is why we risk stratify, right? And if you're young, you're premenopausal, and you have a strongly estrogen-driven breast cancer, and you have lymph node involvement, your oncologist will probably talk to you about, let's shut your ovaries down, give you the aromatase inhibitor, give you kind of exemestane, because we have data, it's called TEX and soft clinical trials, that showed like a huge survival benefit. And so that ovarian function suppression, we now know is so important. So shutting those ovaries down. And typically when you're 30, right? If we do it for 5 or 7 years, you're finished when you're 37, 38. And if you want to have children then, it's your decision if you go through an IVF process, if you get a surrogate, you harvest your eggs. Like it's all dependent, and it's very individualized.
That's the thing. All these treatments. I do see a question about PIK3CA, and I don't think we talked about that, but what is the best treatment for metastatic triple negative breast cancer with a PIK3CA mutation?
Yeah, so it's a drug called alpelisib. It unfortunately did not get approval.
Yeah.
So it's not funded. And we
did the survey for that. And
so we know about 30 to 40% of ER positive breast cancers. There is a PIK3CA mutation. This is where we talk about the sequencing, like the next gen sequencing. So genetic sequencing of the tumor. And when that mutation occurs, we actually have treatment. So say you got palbociclib, letrozole as your first line treatment in metastatic ER positive breast cancer. At that point, we would like to test, so you can do it with circulating tumor DNA. So it's a blood test, or we can take your tumor and we can see what your breast cancer tumor and see whether or not there's a PIK3CA mutation through next gen sequencing. And if there is, and that cancer progresses, then the next line would be a fulvestrant plus alpelisib if there is a mutation. We saw that there is a survival benefit. Alpelisib, though, it's an on target, so we're now looking at different kinds of PIK3C mutation inhibitors. The on target side effect is sugar issues, so kind of a diabetic picture.
Oh,
so
wow.
we want to make sure that we monitor the sugars. There's also diarrhea and other side effects, rash. Look at your liver numbers, but it's still a pill form.
Okay. I think we can start to wrap up soon. I just want to ask, there's a couple questions that I think are in that category of post-treatment scans. I see someone just put in post-treatment scans, ? Someone else asked, why aren't we screened annually? It's so hard to try and monitor ourselves. And that's a topic Rethink's been really interested in, is getting more awareness out, even to the GP community or to metastatic patients themselves about what are the signs and symptoms to be aware of. And it's kind of like our understanding, it's kind of like just be aware of everything and any change, report it to your GP. It seems a little broad. But what about this issue of regular screenings and follow-ups? I guess that would be if you're early breast cancer.
So one thing that we do for early breast cancer patients, if you're postmenopausal, regardless if you're triple negative or you're positive, we give zoledronic acid. So we infuse this every 6 months. It's a bone strengthener, and it showed to obviously improve survival by about 2 to 3%. So, Res said, like, is this incremental? That percentage is important because you might think, 2 to 3%, but that's the benefit of an AI over tamoxifen, right? So you continue to make improvements. and any percentage counts. And this prevents really breast cancer moving into the bones, and that's where that survival benefit comes in.
Okay.
And continues to strengthen your bones. That's postmenopausal women, and usually if they're on a aromatase inhibitor. So that is every 6 months for 3 years. And after that, we typically discharge patients. So if you're in a cancer clinic, we discharge you from the oncologist care and we send you back to your family doctor. The recommended.
You're mentioning postmenopausal, but what about premenopausal?
So premenopausal, we try to make you postmenopausal because that's the best benefit if you're ER positive.
Yeah.
We make you postmenopausal, and we, after the 3 years, we refer you back to your family doctor. If you're young and triple negative, we may refer you after 1 to 2 years of follow-up, because we know triple negative, if it doesn't metastasize, and hopefully it doesn't, within 3 to 4 years, chances are you're cured from it. What is the follow-up? You need an annual mammogram. That's the Choosing Wisely. That's ASCO guidelines. That's American Society of Clinical Oncology. That's Cancer Care Ontario guidelines. We don't screen, we don't CTU, we don't do bone scans. There's no evidence that it improves survival. Creates you a lot of anxiety, right? Creates you a lot of anxiety because you live for your scan. So you're not living, you're living for your scan, right? It's a therapeutic CT saying, okay, I got a CT, I'm clear. You don't need to do CTs. Now, if you are getting CTs, there might be a reason why you're getting CTs. Maybe there was something seen on a previous CT. If you have a locally advanced breast cancer, we will CT you. So that's large tumors, heavy lymph node involvement. We're giving you pre-surgery, preoperative treatment. We will do the full gamut of tests. So you've had a CT scan, a bone scan. We'll do a heart scan because we're going to be giving you a treatment that may affect your heart. So these are all the scans we do. And if everything looks clear, I'm not going to rescan you. I may rescan you if there is a lot of residual disease at time of surgery. I've given you all this chemo, and then there's still lymph node involvement. I get nervous because I want to make sure that there's no cancer anywhere else before we embark on still curative treatment. So you'll get a rescan.
Yeah.
But I don't scan routinely. Like if you've been treated and you've had early stage breast cancer, stage 1 breast cancer.
So if you're not being scanned, because you just explained why, but you've been released to your GP and you're getting an annual mammogram. In addition to that, like say you have metastasis and it's to another body part, not to the breast. What should the community be aware of? Back pain, like it's hard to know, is this back pain?
Yeah, so I mean, as I said, back pain, new back pain where it's waking you up at night, that's a red flag, right? Lumps or bumps, or if you're in your annual workup by your GP, you should be having blood work. You should be having fasting, like you should have your lipid profile, your cholesterol levels checked. Thyroid gets checked in a lot of women because thyroid can change, not because of cancer treatment, but it's very common in women and older women typically. So all of these need to be checked, and if something is abnormal, then you go chase it.
Wow.
But you're going to have aches and pains as you get older, as you go into an early menopause. You're going to have aches and pains. You might get some joint aches and pains, but having, sore knees is not breast cancer, right? It's very, very hard. It's very hard to do after you've had chemotherapy and your whole world has been turned upside down with a breast cancer diagnosis and treatment and everything else. Talk to your social worker, talk to your oncologist, talk to your team. Like we're all there. And if you do,
and Rethink certainly here to support.
And Rethink, talk to Rethink. Your team is there. You've got one of my colleagues, phenomenal. I trained with her. I have to put a shout out to her, Dr. Rebecca Dent. She used to be in Toronto at Sunnybrook. She's now in Singapore and the head at Singapore. And she was nominated as the ESMO Female Leader Award, which is a big, it's a European global And it said, and her title was, "It Takes a Village to Raise an Oncologist." And it takes a village to also treat a cancer patient. And she gave a phenomenal talk, but it was very humbling. And it's so important to reach out. You can't do this alone. You can try to do it alone, but it's difficult because it not only affects you, but it also affects so many other people, especially since, you lose your hair. If you're getting chemotherapy, that's the hardest. There's these cold caps that are coming to the market in terms of trying to decrease that risk of losing your hair. We'll see how good they work. And they don't necessarily work with every chemotherapy, but we're trying to do as much as we can for our patients.
Well, thank you so much. We've plowed through a lot of questions and there's always more, but Rethink will definitely save everything that was asked in the Q&A in the chat, and we'll look at figuring out ways to address anything that wasn't answered, hopefully through content in the future. And we will definitely be sharing this video after the fact. We also love to type it all up and transcribe it and do little kind of key takeaways from this talk. We've done that in the past with Dr. Brezden. It's so helpful. So again, just want to say a huge thank you for being here and making yourself available. And I know how intense the year has been for oncologists, and that you have a packed practice and a very busy research life as well, and 2 kids and a dog and a family. So once again, thank you for generously volunteering and donating your time and your brain and answering all these questions for our community. We really, really, really appreciate it. And thank you everyone for being here and for asking questions, because this is how we share information and inform everyone else. So thank you for participating. And yeah, we just want to say thank you to everybody. All right.
Yeah, thank you for joining on a Thursday night before Halloween. Halloween. And if you're on active treatment, please get your 3rd booster shot. It's available.
Oh, that's a good question. Okay,
if you're in
great.
Ontario, and I believe there's other parts too, but you are eligible for the 3rd booster shot. And it doesn't matter what you've gotten. It doesn't matter if you've got Moderna, AstraZeneca before. Please get your 3rd booster.
So anyone who's in active treatment, they don't have to jump through hoops like we had to do advocacy for second dose.
You should get a letter from your treating oncologist. There's a dial-in number, so make an appointment. And to be honest, if someone's been diagnosed with breast cancer the last 1 to 2 years, we're all going to get a 3rd booster shot eventually anyways.
Okay.
It's not a lottery, and I'd rather have, my patients protected.
Amazing. Okay. Thank you, everyone. Have a great night.